will talk about genetics in pediatric kidney disease and go through a couple of cases highlighting instances where it's really important to obtain genetic testing in our pediatric CKD population, and also relate that to adult nephrology and adult CKD. My only disclosure is that this presentation is being supported by Natera. So I'll first go into a case of an 18-month-old girl who's evaluated in the pediatric nephrology office for a history of gross hematuria, which is now resolved by the time the patient came to see us. The patient had a 1-week recent history of a URI that was afebrile. She had some rhinorrhea and a cough. Otherwise healthy, born full term, normal spontaneous vaginal delivery, no problems during the pregnancy, no significant past medical history or surgeries, no hospitalizations. On a repeat urinalysis in the office, she was found to have dark amber colored urine, over 1,000 red blood cells per high power field, no proteinuria, and a urine protein creatinine ratio was done, which was 0.4, which for her age group is normal. Further labs were all normal, including hepatitis, ANA, ANCA, complement levels. The rest of her CBC and her CMP were all normal. After much discussion with the parents, they opted to observe the patient, and the patient was seen every 4 months for the next year, yet she developed an increase in her urine protein to creatinine ratio from 0.6 to 1.0. The parents at that time refused a kidney biopsy due to the patient's young age and the parents' reluctance to have the patient undergo anesthesia at that young of an age. Over the course of the next year, the gross hematuria resolved but recurred between 5 and 6 times, usually associated with a URI, but sometimes it didn't seem to be temporally correlated with any URI symptoms. The differential diagnosis to our team was a post-infectious glomerulonephritis, IgA nephropathy, thin basement membrane disease, and possibly some other type of glomerulonephritis. At age 3.5, the parents finally agreed to have a biopsy done when the urine protein to creatinine ratio increased to 1.2. The biopsy showed on light microscopy some interstitial fibrosis. The immunofluorescence showed an absence of alpha-5 type 4 collagen and a mosaic patchy staining. EM showed diffuse thinning of a GBM and few areas of irregular and multilaminated appearance of the lamina densa, 1 sclerosed glomeruli, and mild effacement. The diagnosis was hereditary nephritis or Alport syndrome, autosomal recessive type on subsequent genetic testing. Clinical significance for this case is that Alport syndrome or hereditary nephritis does have, as we've heard earlier in this session, extrarenal manifestations, including sensory neural hearing loss and eye findings. Knowing the clinical diagnosis will enable us to counsel the family in terms of future family planning, to look for these extrarenal manifestations, and to see how carefully we really need to monitor kidney function. So genetics could have been aided in earlier diagnosis, which ended up being completely different from what the clinicians had initially predicted. So in this case, the genetic testing did not really coincide with what we thought would happen clinically. And this case, I think, reflects what everyone has been saying so far, that genetic testing is really important for therapy planning, family planning, and for looking for other extrarenal manifestations that can impact the patient.